Good afternoon. My name is Mina Sanchez, and today I will be presenting my evidence-based proposal to improve early identification of adolescent eating disorders in pediatric primary care. This presentation focuses on why these eating disorders are often recognized late, why that delay matters clinically, and why a structured, standardized screening workflow is the most feasible evidence-based practice change to improve earlier recognition and referral. Eating disorders are serious psychiatric illnesses that commonly emerge during adolescence, and they are associated with substantial medical and psychological harm. The central problem I am addressing is that delayed identification remains common even though pediatric primary care is one of the main healthcare settings where adolescents are seen repeatedly. When early symptoms are missed, youth may not be identified until their illness has progressed. My interest in this topic is also professional because pediatric nursing places us in a key position to notice subtle changes, promote earlier intervention, and support families before symptoms become more severe. The specific clinical problem is delayed recognition of adolescent eating disorders in pediatric primary care. In this setting, recognition often depends on visible symptoms, low body weight, or provider suspicion instead of a consistent screening process. My thesis is that the most feasible evidence-based solution is implementation of a structured, standardized screening workflow. In other words, the problem is not that screening tools do not exist. The problem is that they are not used consistently enough in routine adolescent care. For this presentation, adolescence refers to youth receiving routine care in pediatric primary care settings. Eating disorders including anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, and other specified feeding or eating disorders, or OSFED. Pediatric primary care is defined here as the frontline setting where routine preventative visits and other common adolescent visits occur. Standardized screening means using a brief, structured assessment routinely rather than waiting for obvious warning signs. The SCOFF questionnaire is one example of a brief screening tool. In this proposed solution, the APRN role includes evidence, translation, workflow leadership, assessment, education, and referral coordination. The significance of this problem is substantial. Eating disorders are among the most serious psychiatric illnesses affecting adolescents. Approximately 9% of the U.S. population will experience an eating disorder during their lifetime. An onset commonly occurs in early to mid-adolescence. In addition, eating disorder-related health visits among youth under age 17 more than doubled between 2018 and 2022. OSFED accounts for a substantial proportion of these cases, and fewer than 6% of affected individuals are medically underweight. That is important because it means many adolescents do not look like the stereotype clinicians may expect, which contributes to missed opportunities for early recognition. Early identification matters because no body system is spared from the effects of eating disorders. As these illnesses become more severe or chronic, complications can include bradycardia, hypotension, electrolyte abnormalities, delayed growth and puberty, endocrine disruption, gastrointestinal problems, bone loss, and cognitive impairment. Purging behaviors can also create acute instability, including hypokalemia, acid-base disturbances, and cardiac risks. At the same time, the literature shows that many complications are reversible with early effective treatment. So the clinical importance of early recognition is not only about diagnosis, It is also about preventing avoidable medical deterioration and reducing the need for more intensive care later. To examine this problem, I conducted a structured review of the literature. Databases searched included CINA, HL, PubMed, PsycInfo, and Google Scholar. Key search items included adolescent eating disorders, primary care screening, SCOFF questionnaire, early identification, delayed diagnosis, ARFID, bulimia nervosa, binge eating disorder, and pediatric eating disorder screening. Priority was given to peer-reviewed systematic reviews, clinical guidelines, observational studies, and pediatric-focused research, with seminal older sources included when directly relevant. Rather than simply cataloging studies, I reviewed the literature critically to identify recurring explanations for delayed recognition and the most feasible practice change to improve earlier identification and referral. The first major theme was that eating disorders are frequently recognized late in adolescence. Across the literature, adolescents often had significant symptoms before diagnosis and frequently interacted with healthcare providers prior to detection. Many were not identified until weight loss, medical instability, or entrenched disordered behaviors had already developed. This is clinically important because earlier intervention is associated with improved outcomes, better recovery, and less severe progression. The second theme was that delayed recognition is driven by inconsistent screening and by over-reliance on visible symptoms, BMI, or provider suspicion. The literature suggests that eating disorders are often missed not because they are rare, but because clinicians may still associate them with visible emaciation or a narrow stereotype of who is affected. This leads to missed cases among adolescents who present atypically, including males, higher weight youth, and racially and ethnically minoritized adolescents. These findings show that a symptom-triggered approach is not equitable and does not reliably support early detection. The third theme was that brief standardized screening tools offer a feasible strategy to improve earlier identification and referral. Tools such as the SCOFF questionnaire are brief and practical enough to use in routine settings, and structured workflows can improve consistency. Although evidence is still developing regarding universal screening outcomes in pediatric populations, the literature supports the practical value of integrating standardized questions, clinician education, and referral pathways into routine care. So, the most feasible practice change is not development of a new tool, but consistent implementation of tools that already exist. In summary, what is known is that delayed recognition is common, screening tools already exist, and earlier identification matters. What remains less clear is how best to implement routine screening in pediatric primary care and what downstream outcomes are most affected, such as referral completion, treatment engagement, and symptom severity at diagnosis. Important gaps also remain for younger adolescents, males, higher weight youth, and racially and ethnically diverse populations who may be underrecognized. Future research should focus on implementation strategies, workflow adoption, referral outcomes, and more culturally responsive approaches to equitable screening. This problem is also shaped by broader social and cultural factors. Media and social media can intensify body dissatisfaction and unhealthy comparison, while stigma may reduce disclosure and delay help seeking. Cultural stereotypes about who does or who does not have an eating disorder can also contribute to under-recognition. Ethically, screening must be done with privacy, sensitivity and confidentiality, especially in adolescent visits. Health literacy is another issue because youth and families may not recognize restricted eating, binging, purging, or compulsive exercise as clinically significant. Spiritual factors may be protective for some adolescents, but they can also be complex depending on how beliefs are experienced. For families and communities, this problem can lead to distress, confusion, and difficulty navigating fragmented systems of care, which is why interdisciplinary support and community referral partnerships are so important. The conceptual and theoretical framework guiding this proposal is the health belief model. I selected this model because the proposed intervention depends on changing provider screening behavior. In current practice, providers may not perceive all adolescents as susceptible to eating disorders, especially when patients do not present with low body weight or stereotypical features. Providers may also perceive barriers such as limited visit time, discomfort with asking sensitive questions, or uncertainty about referral pathways. The key health belief model elements most relevant here are perceived severity, perceived benefits, perceived barriers, cues to action, and self-efficacy. In this proposal, education increases awareness of severity and benefits. EMR prompts serve as cues to action, and clear referral pathways strengthen provider confidence in the next steps. The APN role is highly relevant to this problem. Advanced practice nurses are positioned to translate evidence into practice, provide staff education, build workflow supports, and improve care coordination. In addition, APRNs bring strong assessment skills that are essential for identifying eating disorder risk, evaluating safety, and recognizing broader health consequences affecting growth, development, mood, and overall functioning. This role also includes family-centered education, trauma-informed communication, follow-up monitoring, and helping adolescents connect with behavioral health dietitians and specialty services. Because this issue crosses both physical and mental health, the MPRN can serve as both as a clinical leader and a systems-level change agent. My proposed intervention is implementation of a structured, standardized eating disorder screening workflow in pediatric primary care. This includes routine screening at adolescent visits using a brief, validated tool such as the SCOFF questionnaire, private and developmentally appropriate questioning, electronic medical record prompts, and clear referral pathways for next steps. The goal is to move screening away from optional judgment and toward routine practice. This intervention is appropriate because it directly addresses the main practice gap identified in the literature, which is inconsistent use of available screening tools. The sample population for this intervention is adolescents seen in pediatric primary care. Screening opportunities would include routine well visits, sports physicals, mental health visits, contraception visits, weight management visits, and visits involving concerning symptoms such as weight change, syncope, fatigue, gastrointestinal complaints, or menstrual changes. The workflow would begin with routine screening. A positive screen or ongoing concern despite a borderline result would trigger a focused assessment of behaviors and risk factors, followed by a medical and safety check and referral to appropriate treatment resources. In this way, screening becomes part of a larger clinical process rather than a standalone questionnaire. The expected outcomes of this intervention are earlier identification of adolescents at risk and more timely referral for diagnostic evaluation and treatment. Key evaluation measures would include screening completion rates, positive screen follow-through, referral completion, and documentation of ongoing monitoring. A simple implementation timeline would include month 1 for staff education and workflow preparation, month 2 for screening rollout, month 3 for chart audit and early evaluation, and month 4 for workflow revision based on findings. This process also depends on interdisciplinary and community partnerships, including behavioral health, dietitians, adolescent medicine, specialty care, and when appropriate, school support and spiritual care. In conclusion, delayed recognition of adolescent eating disorders in pediatric primary care is a serious but modifiable clinical problem. The literature shows that many adolescents are identified late, not because early signs do not exist, but because screening remains inconsistent and too dependent on visible symptoms or provider suspicion. Based on the evidence reviewed, routine standardized screening should become a part of standard adolescent care. Earlier identification has the potential to improve outcomes, reduce preventable medical and psychiatric deterioration, and promote more equitable recognition across diverse populations. APRNs are well positioned to lead this practice change, and future research should continue to evaluate implementation strategies, screening outcomes, and equitable models of care. The following 2 slides are the references that informed this presentation. Thank you for your time and attention.